So I'm going to talk about the approach to the child with poisoning in general from a pediatric emergency medicine perspective. As you know, it's one of the common presentations to wards as well as pediatric, like pediatric emergency department, especially if you take LRH. So it's a common presentation, and in children, poisoning is mostly accidental, whereas we see lots of adults coming with suicidal attempts, but in children it's mostly accidental. And the majority of poisonings are non-life threatening. However, there can be events that can lead to severe complications as well as mortality as well. And deliberate poisoning and experimentation with illicit substances are now increasingly being seen compared to what we saw before. Why children are susceptible to poisoning? There is a bimodal presentation in children. One group are the group of young children who ingest the poison mostly unintentionally due to their exploratory or inquisitive behavior, and also due to the lack of sense of danger. Whereas the other group, mostly teenagers, they can ingest poisons both intentionally as well as unintentionally. And deliberate self-harm is increasingly seen in this age group. And also, there are many teenagers who tend to experiment with illicit substances and recreational drugs and then subsequently getting poisoned. So what's the general approach to any child with poisoning? Here, what I want to focus is, to give you the ability to manage a sick child, not the child who comes with no symptoms, who can be observed briefly and sent home. But there can be instances where children present with severe complicated presentations after severe poisoning. So the general approach can be understood based on this abbreviation, RRSI dead. So what do they stand for? So your first step should be, to focus on giving resuscitation. And then after the child is stabilized, then it's important to perform a thorough risk assessment. And then to give supportive care, and then do investigations and do decontamination and enhanced elimination techniques, followed by antidotes, and then lastly to decide where you need to send the child to. So the initial approach can be understood as 3 stages. What we can do before the patient is brought to hospital, especially by the ambulance crew, and then what we can do at the emergency department, the ABCDE approach, and then the disposition for more definitive care. For example, dialysis or like administration of antidotes in an intensive care unit. So what can be done in a pre-hospital setting? So even in Sri Lanka, so when a child met with an accident or ingest a poison, parents might call for an ambulance service, and there is an opportunity to gain IV access and then to monitor the child during this time. And there are like little things which can be managed while the patient being transferred to the hospital. For example, administration of oxygen to a child having breathing difficulty or breathing respiratory depression, or a correction of hypoglycemia to a child who has ingested a poison which can cause hypoglycemia, such as salicylate or an oral hypoglycemic agent, or treatment of a seizure with benzodiazepine, and administration of naloxone, especially the children who accidentally overdose codeine or morphine, and treatment of broad complex tachycardia with sodium bicarbonate. And also there are like some studies done on the clinical efficacy of pre-hospital treatment with activated charcoal, but practically speaking, a little is expected with regard to this from the emergency medical services. So what can we do, as part of resuscitation? So as you all know, so airway takes priority. So where do we need to pay more attention to secure airway? So children who ingest corrosives, uh, which can lead to airway burns, or plants such as plants containing calcium oxalate crystals, which again can lead to burns and corrosion of the oral mucosa, can have their airways at risk. So we have to follow the basics. So look, listen, feel, and then you can do simple maneuvers like jaw thrust, use of airway adjunct, and then you have to move into breathing after securing of airway. So what can you do for breathing? So attention to breathing is especially important in children who poison with agents such as CNS depressants, diazepam, or organophosphate poisoning, which can lead to cholinergic toxidrome, and a lot of secretions can plug and then result in breathing difficulty. So assess using respiratory rate, oxygen saturation, and then the work of breathing. And if the respiratory effort is not satisfactory after correction of airway, you can give bag and mask ventilation until a more definitive airway such as intubation and ventilation is established. And then we move on to circulation. So some children might ingest poisons where you need to pay more attention on circulation. For example, drugs which cause hypotension, ingestion of agents such as beta blockers, calcium channel blockers, can lead to acute hypertensive shock. So your assessment should focus on assessing circulation, including heart rate, pulse volume, capillary filling time, blood pressure, and then resuscitation should be with 20 ml per kilo of crystalloid fluid boluses. And some agents, like if you take beta blocker overdose, child can be quite refractory to crystalloid fluid boluses alone. And your definitive treatment would be high dose insulin euglycemia therapy, which is used as a inotrope. And then use of inotropes and vasopressors should be done very carefully. And if you are in doubt, an opinion should be sought from the toxicological services. And some children might present with cardiac arrhythmias, for example, who ingest oleander or tricyclic antidepressants. So specific treatment with regard to correction of antiarrhythmics may be needed. And moving on to D, assessment of disability. Poisons such as CNS depressants or oral, overdose of oral hypoglycemics can lead to acute CNS depression. So in these children, attention should be focused more on assessment of disability using AVPU scale or Glasgow Coma scale, pupil size and reaction, and then you can assess and correct seizures. And if the blood sugars are deranged, then attention should be paid to correct hypoglycemia. And then E, exposure. So what we are mostly concerned in E is correction of temperatures. Some of the poisons can lead to hyperthermia. So what are these poisons? Hyperthermia in toxicology can happen due to agents that cause sympathomimetic overactivity or anticholinergic overactivity. So poisoning with sympathomimetic agents. So I will talk on what these agents are later on, or anticholinergic agents such as ingestion of athana, or certain toxicity syndromes like serotonin syndrome or salicylate. So children or young people who overdose these agents can present with hyperthermia. So during the assessment of exposure stage, temperature should be taken, and if the child's temperatures are high, then child should be treated with active cooling using external and internal methods. And it is important to remember that use of paracetamol or antipyretics have no place in correcting these types of hyperthermia induced by poisoning. So that is your ABCDE approach. So now let's move on to decontamination. So what we use commonly for decontamination is activated charcoal. And its recommended dose in children is 1 to 2 grams per kilogram. And it has to be given to have its best effects within 60 minutes of ingestion of the toxin. And however, where depending on the situation, it can be administered up to 4 hours post ingestion, especially who present with life-threatening overdoses or present with slow release preparations. However, administration of activated charcoal can be difficult in children because it's quite unpalatable, and it's not happily accepted by most children because of its taste, and also it tends to be vomited out. So one of the techniques that you can use if you want to administer activated charcoal is to give it by mixing it either with yogurt or ice cream. That will increase its palatability as well as acceptance. It's important to understand that activated charcoal cannot be used to inhibit counter the overdose of ionized substances such as iron, lead, mercury, as well as acids and alkali. So we should not use activated charcoal in these settings. And also, use of activated charcoal is contraindicated if a child presents after ingestion of corrosives, or if you have a doubt whether the patient is having bowel obstruction or perforation, or where the patient is at high risk of aspiration following reduction in the level of consciousness. The other options, one option is gastric lavage. However, it's no longer routinely recommended. It has only limited indications because there is no clinically significant benefit in most poisonings. And also it has the serious complications such as aspiration as well as electrolyte imbalances when administered without proper precautions. It has a role in instances where use of activated charcoal is not allowed. For example, if a child presents with iron overdose or mercury, lead poisoning acutely, so you can use gastric lavage to do a washout and then quickly remove those tablets. In history suggests, history says, there were children treated with the syrup of ipecac, but it's no longer used in clinical practice or as a home remedies. So that is the decontamination. So there are other methods also. So once the child has taken an overdose, we have to use techniques to prevent the effect of that poison on the body. So one method is decontamination. So decontamination means we try to prevent the poison from getting absorbed from the gastrointestinal tract, because activated charcoal absorbs the poison onto that and then gets excreted. The other method where you can get rid of the poison is after the poison gets absorbed to the circulation. So here, toxin elimination means after the poison gets into circulation, we try to get rid of it, get it out, either excreting it through urine, or either trying to get it back to the GI tract and then facilitate the excretion in the GI tract. So multiple dose activated charcoal is one of the toxin elimination methods. It is used to absorb drugs which has significant enterohepatic circulation, which means even if the drug is absorbed, once it's secreted back to the GI tract through the bile duct, charcoal gets bound to that and then gets rid of it. So multiple dose activated charcoal is used in children who poison with oleander or digoxin, carbamazepine and phenobarbital. So all of these poisons, or all of these toxins do have this enterohepatic circulation property. So when administered, multiple dose activated charcoal and administered, even if the drug is initially gets absorbed, but because it's getting secreted back to GI tract, then MDAC helps removing the poison through the GI tract. And also multiple dose activated charcoal is useful in instances where the poison forms concretions or besovas inside the GI tract. one of the well-known drugs or poisons is the salicylate. So salicylate, when especially slow release preparations, slow release aspirins, they are well known to form bezoars, and they remain in the GI tract for a longer time before subsequently getting absorbed. So when you use MDAC, these concretions or bezoars can get easily, you can get them removed without them being absorbed to the circulation. And another elimination technique is the urinary alkalinization. So here you try to get the poison out and then excrete it through urine. So for urine alkalinization, you need to use IV sodium bicarbonate, usually given as a bolus followed by an infusion. So this helps in eliminating drugs that are principally excreted through kidneys. For example, salicylate. So salicylate, it's a weak acid. So when you do the urine alkalinization, your urine becomes very alkaline, and then this weak acid gets bound to that and then prevents it from passively diffusing back or reabsorbed through the tubules to the circulation. So in that way, urinary alkalization promotes elimination or excretion of salicylate through urine. And in this, for urine alkalinization to be successful, you have to keep the urine pH between 7.5 to 8.5, which is the alkaline pH, with administration of sufficient sodium bicarbonate. However, as you know, it's sodium bicarbonate has a lot of sodium as well as bicarbonate. It's important to do electrolytes and blood gases during the treatment. And whole bowel irrigation is another decontamination method. Here, you infuse polyethylene glycol electrolyte lavage solution into the stomach at high flow rates. So this is especially useful for the toxins where you cannot use activated charcoal. For example, iron or lithium, like you can do gastric lavage. If there is a significant, like a large overdose, gastric lavage alone may not be successful. So you have to do whole bowel irrigation. And whole bowel irrigation decreases the enteric transit time, and also it suppresses the time the toxicant has with the GI mucosa, facilitating its excretion. And hemodialysis is one of the other well-known toxin elimination technique. Hemodialysis is used where all these other measures either are not alone sufficient to reduce toxicity, or the patient presents with significant life-threatening toxicity, so that you can use hemodialysis to get rid of the poison. But you cannot do hemodialysis in all situations. It depends on the poison. So this poison should be a dialysable one for that to be for the procedure to be successful. So what are these qualities? The poison should have a small volume of distribution, and should have a smaller molecular size, small enough to go through the dialysate membrane, and it should be water soluble. Lipid soluble ones won't be eliminated through hemodialysis, and it should have low protein binding capacity. So the poisons or the toxins which have these qualities can be dialyzed. So examples include salicylates, lithium, theophylline, and toxic alcohols. And another method is called charcoal hemoperfusion, which is rarely used in Sri Lanka. The method is similar to hemodialysis. However, the cartridge you use in charcoal hemoperfusion contains charcoal, not a dialysate. So charcoal uses adsorbent properties and remove the toxin through the adsorbing to the charcoal. So example poisons or toxins include theophylline, barbiturates, and carbamazepines. If you can remember the previous slides, all these drugs can also be removed from multiple dose activated charcoal because they get absorbed to activated charcoal. So once you do ABCD approach and then institute decontamination and elimination, one of the most crucial steps then to perform is to do a risk assessment. So risk assessment tells you whether the child has taken a significant overdose or a trivial overdose. And also you can predict whether the child will go on to develop complications or not. And also you can decide where the child is going to end up, whether they can be discharged or whether they need to be admitted to ward or whether they need to go to intensive care unit. So it is defined as a distinct cognitive process through which the clinician attempts to predict the likely clinical course and potential complications for an individual patient. So there are 5 components. So you have to determine the agent or the drug. This may be difficult in children because most of the time children, they are not, they are not, they don't tell most of the time that they ingested drugs. And usually parents also do not suspect unless they become symptomatic. For example, parents might not recall, parents might not be concerned until they find a drowsy child who has ingested a sedative agent. So it can be difficult at times. So you need to decide on the agent and also then to decide on the dose. So similar to deciding on the agent, determining the dose can also be very difficult at times. And the time since ingestion. So this tells you, whether you have a time window to administer decontamination or antidotes. And then assessment of the current clinical status. So you have to take observations and also you have to specifically look for toxidromic features. And then finally, the patient factors, which include comorbidities such as obesity or underlying liver or renal disease, and patient's weight. So what supportive care you can, in general, you can give to children who comes with poisoning. So you can give fluid therapy, and in some instances you can give antiemetics and analgesics, sedation. The children who struggles or who have agitation after poisoning, they can be sedated. And attention to glycemic control, catheterization, anti-decompression, temperature control, and assessment of the psychosocial status. So these are like general things, but I will go on to discuss individual supportive care when we talk about individual poisons. So what investigations can you do in general to a child with poisoning? So first line investigations, you can do electrolytes, blood urea, serum creatinine, blood glucose, liver functions, blood gases. But this doesn't mean that you have to do all these investigations for a given child, but these are the kind of investigations you can consider doing depending on the situation. And osmolar gap determination is helpful, especially if you see an unexplained high anion gap metabolic acidosis. And what about urinary toxicology screen? For example, determination of urinary sedative levels, morphine levels, benzodiazepine levels. They are not used in practice because they are not useful in the initial management and the results are not readily available. However, they may be performed for diagnostic purpose, to prove that someone has taken a sedative drug, for example, in sports medicine. So in that sense, they can be helpful, but in emergency situation, this test is not helpful. And you can do quantitative drug levels if available, but in Sri Lanka, most of the time, these quantitative drug levels are not available. So one of the common instances that are used is the paracetamol level following paracetamol poisoning. And the other substances where you can do a level include salicylate, iron, lithium, digoxin, theophylline, ethylene glycol, methanol, carboxyhemoglobin, methamoglobin, and levels of anticonvulsants in blood. And you can consider doing radiological investigations like plain abdominal radiographs, especially in children who ingest radio-opaque material like iron, lead, mercury, cocaine, calcium, or enteric coated agents which can appear radio-opaque. And doing an ECG is very important when children presents with cardiotoxic agents like Oleander and Tricyclic antidepressant poisoning. And then the next step is the administration of antidotes. So antidotes are available only for like a limited number of poisons, not for everything, and they effectively neutralize the effects of the toxin as soon as possible to counteract toxicity. However, antidotes can have their own significant adverse effects. So we have to be very careful in treating children with antidotes, and if doubt, always seek opinion from a toxicologist. So disposition, in most cases, children coming with poisoning require admission to ward for at least brief observation. If you are deciding to discharge from the emergency department, then you have to take thorough history and perform a thorough risk assessment to rule out the need for admission. And also, not only the medical factors, also consider the social circumstances, including the parental level of understanding and confidence, and their ability to come back to emergency department in if the child goes on to develop symptoms. And any suspicion of deliberate ingestion that indicates underlying psychological, psychiatric or psychosocial issues, or incompatible history suggesting possible non-accidental injury should prompt you to admit children for detailed evaluation of non-accidental injury. So let's look at individual poisons. I'll first talk about paracetamol poisoning. It's the most commonly ingested medicinal poison in our children. It can be poisoning can be due to acute single exposure or ingestion following repeated supratherapeutic ingestion. For example, a parent giving a higher dose of paracetamol over a couple of days. And you need to consider the drug formulation, the dose, the time since ingestion, and if available, a paracetamol concentration, and the clinical and lab features of acute liver injury when you assess a child with paracetamol poisoning. And in general, a toxic dose, a single ingestion of a toxic dose of more than 200 milligram per kilo is potentially toxic and is an indication to start treatment with a standard regime of N-acetylcysteine. So we don't have this paracetamol levels in our country, except in like a few stations like National Hospital, but it is also not consistently available in National Hospital. So where the paracetamol levels are available, you can use this paracetamol nomogram reliably to select patients needing treatment as well as to guide ongoing treatment. So here the red line indicates the treatment threshold, and on one side the concentration of paracetamol given in micromoles per liter, and on the other side in milligrams per liter. So this means so at 4 hours an ingestion of one criteria is if a child has taken more than 200 milligrams per kilo, then you need to administer NAC. However, if you are not sure, if the history is not clear, and if paracetamol levels are available, then you can do this level. And if your 4-hour paracetamol level is above 150 milligram per liter, then again you need to consider treating those children with N-acetylcysteine. So it's important to realize paracetamol nomogram can only be used in acute ingestion of immediate release formulations with a known time of ingestion within the first 24 hours. And then so you can administer activated charcoal in paracetamol poisoning up to 4 hours following ingestion. However, if the child presents with elixir or the syrup form, you have to administer activated charcoal within 2 hours for that to be effective. Otherwise, most of the paracetamol will get absorbed to circulation. And then your time frame for to do the paracetamol level is somewhere between 4 and 8 hours post ingestion. So conventionally, paracetamol, N-acetylcysteine was administered as a 3-bag regime. So you administer 150 milligram per kilo over 4 hours, followed by 50 milligram per kilo 1 hour, followed by 100 milligram per kilo over 16 hours. However, the recent guidelines have changed this 3-bag regime to a 2-bag regime, which recommends uh, uh, NEC a dose of 200 milligram per kilo to be administered over 4 hours, followed by 100 milligram per kilo to be administered over 16 hours. And if you look at the nomogram, uh, if you have the paracetamol level, and if you can uh, do a paracetamol level and then check in the nomogram. So we discussed that the indication for NEC is 150 milligram per liter. But if your concentration is double that, then your second bag should be 200. So literally what it means is you have to give double dose of NEC for children with massive overdoses of paracetamol poison. And then, so once it started, so you have to continue it at a stretch. So it has to be given for a 20 hours duration. So there is no like half dose, so you can't stop midway. And to decide whether you can stop at 20 hours, then 2 hours prior you have to do liver functions and if available a paracetamol level. But don't worry if you don't have a paracetamol level, you can make a decision based on ALT and INR, based on those two. So if a paracetamol level is available, if that's more than 10 milligram per liter and ALT more than 50 units per liter, then that means that you have to further continue the second bag of NEC at the same rate. And in Sri Lanka, we use methionine as well. Why we use methionine is it's quite cheaper compared to administration of N-acetylcysteine. And the Sri Lankan guidelines recommend methionine for children who present within 8 hours of potentially toxic paracetamol ingestion, which is 200 milligram per kilo. And we can use this, in situations where NEC is not available. So it's cost effective and it's reasonably safe. And also the dose-related anaphylactoid reactions and vomiting are also less compared to N-acetylcysteine. However, patients should not have any vomiting and should have no underlying history of liver disease if methionine to be administered. So let's look at how we can manage repeated supratherapeutic paracetamol ingestions. Repeated supratherapeutic ingestions include intake of more than 200 milligram per kilo over 24 hours or more than 300 milligram per kilo over 48 hours. How can we manage them? Now here we can't use the paracetamol nomogram. Here, if we do a paracetamol level, they are not going to be reliable because this is like a cumulative effect of multiple supratherapeutic overdoses. So what we can do is, if a paracetamol level is available, you do it, or else you do liver functions, ALT. And if the paracetamol level is less than 20, or if your ALT less than 50, then it's unlikely to be a toxic. It's unlikely to be a toxic ingestion, and then you don't need to treat with NEC. However, if your liver functions levels ALT more than 50, or if paracetamol level available, if it's more than 20, then you have to continue NEC. And then, similar to previous scenario, you have to continue NEC until your liver functions become below 50, or if paracetamol levels available, until it becomes less than 10 milligram per liter. So, remember, for decision making in paracetamol poisoning, as treatment endpoints, you can use INR and liver functions, as we do not have paracetamol levels. So take liver functions ALT less than 50 and INR less than 2 as therapeutic endpoints. So towards the end of your neck infusion, if your INR is less than 2 or ALT less than 50, you can safely stop neck infusion. However, if your ALT more than 50 or INR more than 2, what the guidelines recommend is to further continue neck infusion, monitoring these parameters. And then let's look at oleander poisoning. So oleander, or in Sinhala known as Kaneru, is a common poison, still a common poison, commonly ingested by children and adults in the dry zone of Sri Lanka. It's not commonly seen in the Western province. So the toxin is, so they have naturally occurring cardiac active steroids. The management of oleander poisoning is quite complicated because it's very difficult to predict the outcome. Oleander releases the toxin in an unpredictable manner, and determining dose-response relationship can be very difficult. Therefore, like we discussed, to perform a risk assessment in case of oleander, it's going to be very difficult. Therefore, what is recommended is if a child presents with ingestion of oleander, you have to at least observe them after 72 hours because they can have delayed onset cardiac toxicity. They might appear very well within the initial 6 to 12 hours, but towards second day, they might become quite unwell. So this ECG shows a complete heart block of a child who has ingested oleander. So oleander gets absorbed to activated charcoal. Therefore, if you see a child, if you encounter a child with oleander poisoning, administer activated charcoal. And you can even administer multiple dose activated charcoal because its absorption is erratic and its absorption can be prolonged, like we discussed before. Therefore, if that's a significant poisoning, always go on to administer multiple dose activated charcoal. However, if you treat this child with bradycardia with atropine, what atropine can does is it can cause ileus, and using activated charcoal in the presence of ileus can be tricky because it can lead to bowel perforation. So you have to keep in mind this factor when administering multiple dose activated charcoal to treated children with oleander poisoning. And activated oleander is not amenable for extracorporeal elimination, therefore it has no place. So it's important to monitor ECG rhythm as well as cardiac parameters for up to 72 hours in all children who present with oleander poisoning. And also oleander can cause, because of this effects on the cardiac channels, it can cause hyperkalemia. So you have to look for changes of hyperkalemia in ECG at regular intervals. Serum digoxin levels are available in some countries, but it has only limited place in monitoring because there is no dose related relationship with the toxicity. Therefore, it has no good therapeutic, good use in monitoring the children with yellow oleander. So your main treatment, so treat hyperkalemia if present. So you can treat hyperkalemia with conventional treatment with salbutamol nebulizations, correct, sodium bicarbonate if in presence of metabolic acidosis. However, remember not to administer calcium gluconate because of this calcium channel blocking properties. Intracellular calcium concentration is going to be high. So if you administer IV calcium gluconate more, that can give rise to intracellular calcium toxicity, leading to the phenomenon of stone heart. Therefore, you can treat with all conventional measures the hyperkalemia except using calcium. And then atropine can be used as a bridging treatment for those with heart blocks. and you can use cardiac pacing. The definitive treatment for yellow oleander poisoning is antidepressant, which is the antidote. And let's look at kerosene oil poisoning. It's the most commonly ingested poison in children in our country. Most exposures are benign, so children are quite well, apart from having a brief difficulty in breathing. And this is poorly absorbed from the GI tract. However, you can have very severe complications in a massive overdose, such as aspiration or CNS complications, including coma or convulsions. And kerosene oil also can lead to cardiac arrhythmias in severe toxicity, such as atrial or ventricular fibrillation. And also it can lead to organ failure as well as toxicity to bone marrow and kidney. And contamination of the skin and mucous membrane leads to irritation of the skin. So management of kerosene oil is supportive and there is no antidote available. You have to remove the possible source of poisoning. And if the child is having difficulty in breathing, you can start on supplemental oxygen. And if there is significant hypoxia or significant respiratory distress or evidence of aspiration with hypoxia, child might need intubation. And if the child is having contaminated clothes, they need to be removed. Do not administer any decontamination measures as it can be detrimental, and kerosene oil can lead to aspiration and subsequent chemical pneumonitis. There is no place for routine use of corticosteroids, and they need, that need to be decided on a case-by-case basis. Similarly, there is no routine place for routine prescription of antibiotics. However, it also needs to be decided on a case-by-case basis only in the presence of secondary bacterial infection. Let's look at salicylate poisoning. It's again aspirin, no methyl. So children can ingest methyl salicylate balms or aspirin tablets. It's again one of the very toxic agents. Children can be, toxicity can be due to both acute as well as chronic exposure. It can have toxicity over, multiple organs. It's cardiotoxic. It's toxic to CNS. It's toxic to lungs. It's toxic to GI tract. So multisystemic toxicity is observed. How can you manage salicylate toxicity? So there is no antidote available for salicylate poisoning, and the supportive care is the main mode of management. What you can do is, so you need to get rid of, in severe overdose, the mainstay of treatment is, enhancing elimination of this poison from circulation. So, you can use activated charcoal, even multiple dose activated charcoal, if you have a doubt about salicylate forming concretions or bezoars, and you can use elimination methods like urinary alkalinization to encourage salicylate to be excreted through urine. With regard to the support of breathing, children with severe toxicity might need intubation, especially those with altered level of consciousness or features of acute lung injury. However, because intubation can lead to acute acidosis, make sure that you treat with IV sodium bicarbonate bolus and pre-oxygenate with bag valve mask hyperventilation prior to intubation. So that will prevent accumulation of increased salicylate concentrations within the central nervous system. So treatment-wise, GI decontamination with activated charcoal and elimination with multiple dose activated charcoal are indicated. If the facilities are available, but in our country this facility is not available. Where facility is available, you can do salicylate concentrations to identify the trend in toxicity. However, for us, as salicylate levels are not available, in our practice, the toxicity should be guided by blood pH. because salicylate lead to severe metabolic acidosis. So metabolic acidosis represents toxicity due to salicylate. So sequential blood gases and determination of pH is helpful in determining the trend in the toxicity. And salicylate can lead to hypoglycemia as well as neuroglycopenia. In a child with salicylate poisoning, you have to treat with dextrose even if their blood sugar is normal, especially if their consciousness level is reduced. And also they might go into shock, so you have to treat with fluid resuscitation. So the two definitive methods, like more definitive methods of management, are the elimination with urinary alkalization and hemodialysis. So in any child with severe poisoning, urine alkalinization should be tried first. So like we discussed before, here salicylate is a weak acid. By making the urine more alkaline, we try to dissolve weak acid in that and then try to prevent reabsorption of salicylate through the tubules back to the circulation. So we try to get rid of the poison through that pathway. For that, you have to maintain urine pH between 7.5 to 8 and a urine output of 2 to 3 ml per kilo per hour. So you have to give IV sodium bicarbonate bolus followed by an infusion. And during this process, you have to monitor blood gases as well as serum electrolytes to prevent the toxicity from sodium bicarbonate. And in life-threatening overdose, or where urine alkalinization is not going to be, going to cure the child, or where there is underlying renal impairment, then the option is the hemodialysis. So hemodialysis is an effective and a rapid method of enhanced elimination. It has the added advantage of correction of acid-base and fluid and electrolyte abnormalities as well. The indications for hemodialysis in salicylate toxicity are the significant CNS involvement, acute lung injury, impaired renal functions not responding to fluid therapy, significant hyperthermia. So hyperthermia can occur due to salicylate, refractory acidemia, and refractory electrolyte imbalances. Let's look at the next poison, ethylene glycol. So ethylene glycol is again commonly used poison, commonly used agents, especially used in antifreeze coolants in vehicles. Ethylene glycol or antifreeze is a colorless, odorless, sweet liquid. Because of the sweet taste, children tend to taste it and then subsequently getting poisoned. Here, the biochemical hallmark is you will find unexplained high anion gap metabolic acidosis after ingestion of ethylene glycol. How does it happen? So ethylene glycol gets metabolized inside the body and then converted to glycolic acid. So these organic acids remain unmeasurable in the blood gas. So you will find an unexplained blood gas, high anion gap blood gas. And these glycolic acids and organic acids are highly toxic to the central nervous system. It can be toxic to the optic nerve and can result in blindness, and it also can be toxic to the central nervous system, resulting in coma and seizures. And its counterpart methanol can have the similar toxic effects. And if you take sanitizers, which is used frequently nowadays, sanitizers have some amount of methanol. And if you see the cases where people died after sanitizer ingestion in the United States, they died because of the toxicity from methanol. So methanol had a similar toxic effect, leading to optic toxicity and the central nervous system toxicity. In both methanol and ethylene glycol poisonings, activated charcoal is not effective. So your treatment is you can use either fomepizole or ethanol, 40% ethanol as antidotes. And in refractory cases or severe poisoning, you have to do hemodialysis to get rid of the organic acids from the circulation. Iron. So iron is again one of the common toxins. It's used, in iron tablets are used by young children as well as pregnant mothers, as well as women of childbearing age, as a part of the contraceptive pills. So there is a chance that children ingest these tablets frequently. Toxicity is likely in doses over 20 milligram per kilo of elemental iron, and the toxicity can be fatal when ingested a dose of more than 150 milligram per kilo. It has, 4 stages of toxicity. Initially, you can have GI symptoms, and there is a dormant phase followed by significant side effects, including significant toxicity, including GI hemorrhages, convulsions, coagulation dysfunction, circulatory collapse in cases of severe poisoning. So these children might need intubation, ventilation, and circulatory support. Here, there is no place like we discussed before, since they are heavy metals or not amenable for absorption by activated charcoal. What you can use is you can use gastric lavage, or in a significant overdose, you can try whole bowel irrigation to facilitate excretion of these tablets through the bowel, through as effluent from the bowels. And there is an antidote for iron poisoning, which is IV desferoxamine, like we use for thalassemia. And you can IV desferoxamine can be used up to 15 milligram per kilo per hour for those present with complications like shock or coma or fits. This X-ray shows a child who has ingested radio-opaque tablets, which could be iron tablets. And then we will look at the toxicity of tricyclic antidepressants. So these antidepressants are also now increasingly used by adults for sleep difficulties as well as depression. So when they are not properly stored, children can ingest these drugs. And tricyclic antidepressants is one of the drugs with significant cardiac toxicity, because it inhibits fast sodium channels in the brain, myocardium, as well as it has numerous other actions, including blockage of muscarinic and alpha adrenergic receptors. So they can have, due to the blockage of fast sodium channels, they can have cardiac conduction delays, any cardiac arrhythmia, as well as reduced cardiac contractility, as well as, because of the blocking action of the alpha adrenergic receptors, they can cause hypotension. And because the anticholinergic effects, they can have dilated pupils, tachycardia, as well as convulsions. So this shows, excuse me, give me a second, I'm getting a call from the board as I'm on call. චූලනි මම ලෙක්චර් එකක් කරනවා, හදිස්සි නැත්නම් තව චුට්ටකින් ගන්න පුළුවන්. වෙබිනා එකක් කරනවා. තව චුට්ටකින් ගන්නකෝ. Okay. So this shows a wide complex tachycardia induced by the toxicity of tricyclic antidepressants. What can you do in patients presenting with tricyclic antidepressant poisoning? So here, the main toxicity is due to blockage of the fast sodium channels. So you have to counteract this. So here, IV sodium bicarbonate used as an antidote. So it replaces tricyclic antidepressants from the sodium channels, removing the blocking effect. So main treatment in tricyclic antidepressant poisoning is IV sodium bicarbonate. And you try to aim for an arterial blood pH of 7.5. And doing hyperventilation is also helpful, because that will help removing the carbon dioxide produced from the bicarbonate. And child might need volume expansion because of the blocking effect of alpha adrenergic receptors causing hypertension. So if the child is having hypotension, needs to be treated with fluid resuscitation to aim for a MAP of 70 millimeters of mercury. And if you need inotropes to treat TCA poisoning, the inotrope of choice is noradrenaline, because the main receptor it blocks is the alpha adrenergic receptors causing predominant vasoconstriction. So vasodilatation. So in order to reverse that, you have to use noradrenaline. So it's preferable to other inotropes such as dopamine, dopamine, and adrenaline. And glucagon also can be used in severe toxicity for its inotropic effects. And so these are like straightforward presentations. If you know the drug, then you know the treatment, and then you know the end. However, children or teenagers especially might present with less straightforward presentations. For example, a child or a young person can present with a reduced conscious level, where you don't know what happened, or parents also do not know much of information. Or else a young person might present with altered behavior with no explanation. Or a young person can present after ingesting an illicit substance like MDMA. So what is your approach? What is your approach to children and young people like this? Here, so if you are not sure of the etiology or the cause of the poison, then based on the symptoms and the signs the child has on presentation, you can work out a possible toxidrom. There are several toxidroms. So knowing this toxidrom will help you to come to a differential diagnosis and providing appropriate tailor-made supportive care, and then, if available, an administration of antidote as well. So clinical toxidroms, they stand for the clinical fingerprint characterized by a classic constellation of symptoms and signs due to toxic effects of chemicals in the body. And you see these clinical toxidroms more commonly in older children and teenagers who abuse recreational drugs. However, if you are not sure, if the presentation is less straightforward, and the child is, if you suspect a toxidrome, which I will, talk late in the next few slides, you have to think of the other differential diagnosis as well. For example, an unconscious child might present with meningoencephalitis, so it needs to be ruled out. Or they might present with hypoglycemia, acidosis, or with a metabolic crisis. Or they might present with ICH, or significant hypoxia, or hyperthermia, or even septicemia. So you need to think of these differentials in your, in the back of the mind before narrowing down your differentials to a toxidrome. So let's look at what these toxidromes are. First toxidrome is the opioid toxidrome. The opioid toxidrome occurs after poisoning with opiate agents. So commonly used agents like codeine. Codeine comes with panadine, paracetamol, and codeine, which is commonly prescribed. And morphine. Morphine is given to people with chronic pain. So children might child might accidentally ingest them. So their typical presentation is a triad of respiratory depression, CNS depression, and pinpoint pupils. So if you see pinpoint pupils in a child who is unconscious and who is not breathing, who is having bradyapnea, then you have to strongly suspect ingestion of an opiate. And this is especially true, heroin. Heroin is an opiate. Heroin is like a commonly abused drug by the teenagers. So intoxicated teenager might present with these three triads: respiratory depression, CNS depression, and pinpoint pupils. So why it's important to know this is, like, you can rapidly reverse this toxidrome by administering the right antidote, which is naloxone. And there is another toxidrome which goes very close to opioid toxidrome, and that is induced by intoxication with sedatives. Sedatives like ingestion of diazepam, lorazepam, these anticonvulsant medications, as well as children or young people who get intoxicated with alcohol. So they will have, in severe poisoning, they will have respiratory depression, they will have CNS depression. However, their pupils are not pinpoint, but can have a variable size, can be dilated at times, can be small at times, not pinpoint. And they can have, in addition, circulatory problems as well. They can sedative toxidrome can lead to hypotension and bradycardia. So here, if a child presents with this sedative toxidrome after ingestion of diazepam or alcohol intoxication, then naloxone is not going to be effective, and this needs to be treated with supportive care. So you may have to give ambu ventilation for a brief period of time. You may have to monitor Glasgow coma scale over time. And if there is a concurrent low blood sugar in alcohol intoxication, you have to correct it. So likewise, you need to give supportive care. Although flumazenil is used as an antidote for diazepam poisoning, the routine use of flumazenil is not advocated because especially it can trigger seizures in children who are on like long-term diazepam. And then these three toxidromes, the cholinergic toxidrome, sympathomimetic toxidrome, and anticholinergic toxidrome, they also share some of the features in common. Cholinergic toxidrome, it's a unique toxidrome that you see after poisoning with pesticides. So the more common pesticides are organophosphates and carbamate. And cholinergic toxidrome initially leads to cholinergic crisis. So that is widespread, massive activation of the parasympathetic nervous system, which leads to diaphoresis, lacrimation, urination, diarrhea, bronchuria with lots of bronchial secretions, sometimes lead to respiratory failure, vomiting, meiosis, salivation. So when you see those typical hyperactivated parasympathetic nervous system, then you have to suspect cholinergic toxidrome. So after this cholinergic crisis, patient can soon go into neuromuscular paralysis, including respiratory paralysis and death. So identifying this toxidrome helps you to administer antidotes as well as supportive care early. And then your supportive care include now decontamination. It's trying not to. So this is decontamination is not helpful most of the time. So better not to attempt. This is wrong. I have put it in error. Decontamination has no place in organophosphate poisoning because it can lead to aspiration as well. However, you can use atropine to counteract the cholinergic crisis. And if the child is developing neuromuscular paralysis, you can start. You can do intubation and ventilation. And the definitive antidote is palindroxim. So palindroxim works only for organophosphate and not for carbamate. Here, the main mode of supportive care is atropine. So atropine you can initially give boluses, and then you can try atropine infusions as well. And you have to have therapeutic endpoints while giving atropine, because atropine is also toxic. So you have to monitor your heart rate, you have to monitor your blood pressure, and your axilla for dry axilla, and for your pupils. So you have to monitor these factors while administering atropine. And the sympathomimetic toxidrome and anticholinergic toxidrome, these two share common features, like they look like very similar. However, their etiology is different. Therefore, it's important to differentiate the two conditions. So both sympathomimetic toxidrome and anticholinergic toxidrome share common clinical features like dilatation of pupils, tremors and hyperreflexia, seizures, tachycardia, hypertension, hyperthermia, agitation, delirium, and so on. However, there are few differentiating features. In sympathomimetic toxidrome, you see diaphoresis, whereas in anticholinergic toxidrome, you see dry skin. So that's one of the differentiating factors. So look for the skin, whether the patient is sweaty or having a dry skin. And the other thing is, listen to the bowel sounds. If the bowel sounds are exaggerated, that supports sympathomimetic toxidrome, whereas if the bowel sounds are sluggish, that supports anticholinergic toxidrome. So the etiology is different in these two conditions. If it's anticholinergic toxidrome, then your Alkaline poisoning, atropine poisoning, antihistamine or tricyclic antidepressant poisoning are the etiological agents. Whereas if it's sympathomimetic toxidrome, it's mostly an illicit substance the patient has taken. And this could be cocaine, amphetamine, MDMA. But irrespective of the syndrome, in both cases, as the clinical features are similar and you have only supportive care to give, management is similar. So if the patient is agitated, having delirium, so you control delirium with sedation, benzodiazepines. And then if you have circulatory imbalance, then you correct with fluid resuscitation. And if the patient is having hyperthermia, then you have to start active cooling. Antipyretics or paracetamol has no place in controlling these types of hyperthermia. And the other entity is children and deliberate self-harm. Especially older children and teenagers are vulnerable for self-harming behavior, and they can have significant underlying psychiatric problems like depression. Therefore, apart from managing the medical part, medical illness, once they have recovered, you need to refer them for psychiatric evaluation and support, irrespective of the dose they have ingested. So the key messages from this lecture: although most childhood ingestions are of low lethality, poisoning in children account for significant mortality, and they can be, the presentation can be life-threatening. Therefore, it's very important to perform a correct risk assessment and then tailor-made your management depending on the severity of poisoning. And also in older children, it's very important to identify toxidrome that will help formulating the right differential diagnosis where the presentation is less straightforward.